Yes.
Okay. So this is a youngish person who has had a liver transplant and had a radiograph done for a cough or something like that. And the frontal on first glance looks pretty normal. Here's the lateral, and this was identified here as a finding. We had no, I don't think we had a previous chest radiograph in our system, but this was identified as a potential area of consolidation or nodule. I'll blow it up for you a little bit. It's pretty well defined. If we go back to the frontal view, um, there's really nothing in that area, but we did have a dual energy. So this is the soft tissue subtraction. You can see there's a little bit of black here. That could be part of it if it's calcified, because it looked pretty well defined. But we do get a lot of misregistration artifacts along the heart. So hard to know, but definitely some of the lateral. So they recommended getting a CT scan, which was subsequently done. And indeed, there is something in the left upper lobe there in the lingula, this area of calcification. Very discrete, some air bronchograms. And if you look in a few areas, it's actually kind of almost central lobular. You can make out some sparing on the periphery of the lobules. And we didn't have an old chest CT, but we had an abdominal CT that was 3 months before. And they didn't mention it in the report because I don't blame them. It just looks like you're catching the bottom of the lung. But you'll notice there's this ground glass opacity, very discrete in that same area. So the patient turns out developed some renal insufficiency after their transplant as a complication of liver transplant. So I suspect this is just a very focal area of metastatic calcification, unless others have a different idea.
Nice.
No infection, no nothing. I have never seen it develop this quickly, and it's interesting just how focal it is.
Yeah, I don't know that I've seen it be that focal before, but yeah, I mean, the appearance looks good for
Yeah,
it.
yeah. I was
Hmm,
kind of cute.
cool.
Yeah.
So I've seen cases before of pneumonias and other things that impair the lung that in the presence of renal failure will calcify, and they can
Hmm.
calcify pretty rapidly. So I've seen calcified pneumonias in
Hmm.
people that had kidney failure, and this might have, this could have been an infection. This could also have been an infarct in that area too.
Yeah.
So anything that could lead to dystrophic calcification, it's really accelerated greatly if you have kidney failure.
Right.
And you know, we've seen even calcifications in the heart
Right, for
develop if the
sure.
person had renal failure and then had
Cold
some
stone.
event like
Right. Often the setting of
myocardial.
pancreatitis or sepsis too.
Right.
But as far as I could not find any documented respiratory infection or anything. So,
But there was on abdominal CT, they
right. But I
just
wonder if
didn't
that was the
diagnose it.
beginning of some calcification, like some metastatic calcification, and it's just become denser.
Yeah, or that could have been the whatever was damaging the lung that led to this
Yeah.
calcification later on.
Yeah.
So
Interesting.
yeah.
Okay.
So it's really, the interesting thing is, Jeff, it's really dystrophic slash metastatic calcification
Mhm.
because there's that that dystrophic thing that it probably upsets the pH balance, and
Mhm.
that leads to that, then calcification is really promoted.
Okay. Interesting. Yeah, there's a recent radiographics article, or I think it's in the last year or so, that nicely talks about calcification, ossification in the lungs. This is another cool case talking about calcifications. So this is a patient who has some chronic lung disease, and you can see the radiograph shows a couple things. There are these what look like cystic walls down here. You can see the little walls of some of these cystic spaces. And then there's some branching abnormality here, some airway wall thickening as well. And then there's some pleural stuff and some more parenchymal looking stuff down there. And you can see some scarring towards that area there. So here's the CT scan. The CT scan is quite cool. So there's a little tracheal diverticulum. And you'll notice everything looks pretty normal in the airway for the most part. It's got a little bit of a kind of nodular component, but sometimes we just see that. But as we come down towards the carina, you start seeing the airway gets a little funny shaped. And then as we get further out, the posterior wall starts to thicken up a little bit. And then we get to the bronchus intermedius, and the wall is circumferentially thickened. The lumen is a bit narrowed, and there's this calcium in it. And it's not just cartilaginous. You see a little bit along posterior membrane there. And we go further out to the middle lobe. You can see it's thickened and narrowed, and there's circumferential calcium, so it's not just cartilage. And we keep going down, and there's some occlusion here, and then some pretty tight airways here, and a lot of plugged up airways with some calcium in their walls, and this kind of obstructed lung. And then there's this background of pretty bad cystic disease. And if we look at the distribution of the cysts, many of them are perivascular. There's a vessel running along the wall of them. They are lower lobe predominant. This goes along our protein deposition differential. And it turns out this patient had a salivary gland, a tonsil removed because there was a mass there, and it ended up being an amyloidoma, and it was AL amyloid. So patient does not have Sjogren disease, does not have a plasma cell dyscrasia, but does have a known amyloidosis. So they were going to biopsy this, but I don't think they need to now, because I think this is airway amyloid and this is parenchymal amyloid. And what's interesting is airway amyloid is usually found in isolation, at least the cases I've seen, and that's what's generally described in the literature. It's usually more diffuse, involves the trachea. This is more focal, and I've only seen a few cases that were more focal. But I think that's what's causing all the obstructive phenomena here is the bronchial amyloidosis, and the cysts I can ascribe to the protein deposition in the lungs. So this is presumed systemic AL amyloidosis. There may be probably some minor involvement of the trachea because it doesn't look quite like a normal trachea. There may be a component of malacia in there as well. So amyloidosis.
Very cool.
Yeah.
And that could be an amyloidoma in the right base too.
Yes, maybe so.
Yeah, and the calcification in association with amyloid is often ossification.
Right. Yeah, there we go. Yeah, there's all these nodules down here. All right, this next case is another interesting case. So this is a lung transplant recipient, double lung, was doing fine. And so when they come to clinic, they always get radiographs for whatever reason. And 99% of the time we see nothing acute because they're healthy, they're not sick, so otherwise they'd be in the hospital or in the emergency department. But right here is a nodule that was not there before. And of course, this is a tough spot because you've got a rib end there, but if you look carefully, it clearly extends above the rib end. And if you go to the lateral view, you can see it overlying the trachea. So of course we worry about infection things, tumors, but here's the CT scan, and the only abnormality is this nodule. And you'll see there are air bronchograms in it. It's got a subtle little halo of ground glass opacity, but it's doing nothing to the airway. The airway just passes through it. So same differential, infection or tumor, but when I see a tumor like this, of course, I think of lymphoma, and in a transplant, you think of PTLD. So we favored that over infection, but I would never write off infection in an immune compromised patient. So Nocardia, aspergillus, some other weird fungus, most likely. So they did a navigational bronchoscopy of this case, and this came back as diffuse large B-cell lymphoma Epstein-Barr virus type. So this is PTLD presenting as a solitary pulmonary nodule. So the teaching point for us was these routine, never see anything cases. You got to remember, you got to always be on your toes. It's like chest pain in the ED. You rarely see anything, but every so often something sneaks in there, right? It's a totally appropriate exam, but most of the time the angina or chest wall stuff we can't see. But yeah, so PTLD. And I've seen a couple of these transplants. We've had a heart transplant that had a nodule that ended up being nocardia as an incidental finding. So luckily, I don't know, I mean, there's probably some prognostic value in the fact that it's isolated to one area. So there's no other sites of disease, but PTLD.
I think that's a good reason for screening getting routine chest x-rays, even in the absence of symptoms in this population, because I've seen asymptomatic aspergillus infection, nocardia, and PTLD and cryptococcus in this transplant population with no symptoms, but picked up on a routine
right before they
exam when
become
came to
symptomatic.
clinic.
Yeah, especially with crypto and nocardia, which can so-called metastasize in quotes quickly to the CNS.
Yeah.
All right, and this is my last case, which is a really cool case. So this lady was treated for breast cancer some years ago and has been doing well, but has developed a cough. She's currently on no therapy, so she's not on any immunotherapy. And on first glance, you'll see there's clearly a problem in the left lung. There's all these nodules. They are clearly perilymphatic, and they're forming the so-called fairy ring sign, which is a little well-known sign, one I love to talk about with my trainees. Here's a really nice example. And for me, a fairy ring sign, maybe I describe it differently. It's a reverse halo that has nodules instead of smooth. And when I see this, I always think of granulomatous process. And I found an old case report, I think it was published in Chest, and they describe it in the setting of sarcoid, but it was like 5 millimeter slices, and it was not done by radiologists. So the description was a little bit vague. And there's some references to it on Radiopedia. But so this looks all the world like it could be sarcoid, but what is unusual about it? Well, it's unilateral. And yes, I have seen unilateral sarcoid, but it's always been on the right. And this is a high perfusion disease, which is a little odd to be unilateral. She's had some radiation there. What's interesting, she carries a diagnosis of MAC. This is an old CT from like before she had her breast cancer. She had early on, but it's like this is a long time ago. Now, when I show you what her lungs look like then, you see she's got these nodules. Some are branching, some are perilymphatic, some are tree and bud. What do you think about that?
Well, I'm worried that this is airways infection. She's
Yeah,
colonized
this
with,
looks like an
it's,
infection.
yeah, it could be
Right,
MAC or it could be aspergillus. We've seen airways
right.
aspergillus that ends up looking like
Yeah,
MAC.
but this is all perilymphatic here. So she actually had another sputum positive test, and this time it's not MAC, it's actually Mycobacterium tuberculosis. This is TB, confirmed. Um, and
Wow.
I have seen cases of TB look all the world like sarcoid. And so what I suspect, and I've seen ones that are bilateral that look like sarcoid, I suspect is that sarcoid-like, what we call sarcoid-like reaction can be one response to MTB, right? The granulomas in the lymphatics. And I was trying to see if there was there's probably some tree and bud hiding in here, but it's really hard because you can sometimes see fake tree and bud with sarcoid. You just see branching veins rather than central lobular nodules. But there's something that kind of hints at it maybe. But yeah, this is culture, a sputum positive PCR, and an AFB stain positive MTB. And so and so if you haven't seen a lot of TB, because we don't see a lot of TB in our practices in the US for the most part compared to other parts of the world, I've shown cases like this to people who practice in countries where there's a lot more TB, and they have seen plenty of cases like this. So if it looks like sarcoid and it's a little odd and there's risk factors for TB, don't just say it's not TB. But this is MTB, and I suspect if you biopsied this, you would get some non-caseating granulomata mixed in with the other findings, the more typical findings of TB. That's my theory behind why it looks like TB, sarcoid. But it's very unilateral, which is just odd. All right, so some fun cases.
Indeed.
So either of you can go whenever you want.
Maya, it's all yours.
All right, sounds good. Let me choose this window, this. Share. Okay. So hopefully you can see a CT scan. Yes.
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 Beautiful. So this one I just pulled up as a companion case to the one of the ones that Jeff just showed because your case reminded me of this. So here we have a patient with really, extensive mass-like consolidation here in the right lung, as well as all of these other areas of nodularity. And in the less affected lobes, like the left upper lobe, right lower lobe, they kind of look similar to that nodule you were showing in that lung transplant patient, where they're kind of along the bronchovascular tree. They have airways, air bronchograms going through them that are not super affected. This was a patient who had a renal transplant rather than a lung transplant. And I, for all the world, thought this was going to end up being PTLD. like you had mentioned, but this, as you mentioned on the differential, it turned out to be nocardia. And so this was a
Wow,
patient
that
who was
extensive?
really extensive nocardia. And I think
Gee.
it did eventually, I think the patient was unfortunately not taking their prophylactic medications as they should have, but it got biopsied and then they got treated, and then, you know, after treatment, they looked significantly better, right? It almost all completely resolved with just a little bit of residual scarring. But just, just to not discount that as one of the differentials, particularly in these immunocompromised patients.
Nice
So,
air bronchograms
yeah, right?
should have been PTLD.
I totally agree. It's like great
Yeah.
distribution for it, but
I don't think I've
Maybe
seen
the
that much
nocardia ate the
nocardio.
PTLD.
yeah,
That's a huge burden of nocardia.
it is. I completely agree.
I mean, I've seen consolidation, masses, nodules, but I mean, this looks like horrible disease.
Yeah,
Wow.
yeah.
And
But
how sick was the patient when they presented?
they were pretty sick. They actually presented to an outside hospital and got
Okay.
transferred here.
Okay.
But they did, I think at the outside hospital, did like a core bio or, a CT guided biopsy of this portion of the lung, and that's where the nocardio diagnosis came from. So,
Got it.
yeah. All right. So next case, this one I think is just a nice example of something that I think we, see actually quite frequently, but just, remind us all that this is a thing that exists. So this is a patient who obviously has a very large mass. This is a pulmonary adenocarcinoma. And as we can see, right, it is extending to the mediastinum. Here's our SVC, where it looks like it is probably invading, as well as just, almost completely obliterating that superior vena cava. And so because of that, we see all of these really extensive venous collaterals throughout the chest wall, throughout the mediastinum. We see all these little veins sort of like wrapping around the aorta, around the pulmonary veins, pulmonary arteries. And, that's all kind of an expected finding in somebody whose superior vena cava is down. But this was a patient who, came into the emergency room. And so I don't know how it works at your institutions, but I feel like all these patients come in with cancer and then they ask us in the emergency department to stage their cancer. And so the ED physician or the ED radiologist who was reading this overnight, astutely pointed out that there were some areas that look very dense in the bones that, may be concerning for osseous involvement. However, noted that obviously, right, their venous system is not working particularly well because that SVC is occluded, and so brought up the possibility that this could all be venous enhancement within the bones, all of these areas. And so recommended that we get a non-con, which was done the next day, or 2 days later, I guess, which was this one here. And we see that all of that dense stuff in the bones goes away. So all of that was just contrast and blood. So venous enhancement within the bones rather than true osseous metastases.
That's great. I had a case yesterday I shared with my residents, but it was more obviously contrast because you could actually see it coming in from the venous plexus, and it was so bright. Your case is impressive because it's more amorphous looking.
Totally.
And look at the sternum. That looks like
I think the sternum's the thing that really gets me, because that really looks like an osseous met to me. The spine, maybe not so much. That's really bright and looks more like contrast, but this stuff, I was surprised that it
Can you
just
see on the
away.
axials, can you see the vessels going into the sternum? Because that's not something you typically see. No.
Not really, no. There's
No,
vessels that get close, but they're like not clearly going directly in.
Oh, that's so cool. That's a great case.
Yeah.
I didn't even know about this phenomenon. I mean, this is spectacular.
Yeah, and again, I feel like in the spine, I see it not that uncommonly. Oftentimes it's in people who, have long-standing dialysis catheters, or for whatever reason their, venous inflow is obstructed, and so you just see it a little bit more prominently. And in the spine back here, I do think that you can see the vessels, going directly in to the bone, so less confounding there. But the sternum I've never seen it in the sternum before.
That's incredible.
So, yeah. Okay, who do I have next? This case. So this was one that came up in our, we have a weekly conference with our pulmonary fellows who just bring us interesting cases, and we talk about the imaging of it. And so this was a case that was brought up in that conference. These two CTs, this one is on screen left is from this year, and this is like 4 or 5 years ago on the right. And we can see patient obviously has pretty severe fibrotic lung disease. And as we sort of scroll up and down through this, it's most severe up at the lung apices, right? We can see these really big tortuous traction bronchiectasis, really thick areas of fibrosis. And it's, even more impressive here on our coronal views, where you have this like very thick cap of fibrosis involving nearly the entirety of the upper lobes at this point. And this is obviously significantly progressed over this time. So a really good look for PPFE, pleural parenchymal fibroelastosis, this progressive apical fibrosis over this time point.
And he doesn't have ankylosing spondylitis, does he?
I don't believe so. Let's look.
Look at that.
Yeah.
Nope.
Nope.
Yeah.
But one of the things that I thought was interesting that the pulmonologist brought up was, obviously this patient, well, the vast majority of their fibrosis is at the lung apices. They do also have fibrosis at the lung bases as well. And so the question was like kind of brought up, like, oh, is it possible that this person has both PPFE and IPF? But the more interesting thing to me was the discussion that followed, which is that at this point in our current time in history, it probably doesn't matter whether we make those two separate diagnoses in this person, because the progressive fibrosis from the PPFE is sufficient for this patient to get an antifibrotic medication. Whereas in previous years, you had to be diagnosed with IPF to qualify for that. But now progressive fibrosis from any cause can qualify you for antifibrotic medication.
And how old is this person?
This person is 77.
And is a boy or a girl patient?
Male.
Boy patient.
Boy patient, yeah.
Okay.
So, it certainly is possible that they have two issues going on, but again, I think for treatment purposes for this patient, it's kind of more relevant that they have progressive fibrosis, because that is sufficient to qualify them for therapy.
I would say that basal stuff is not really a very good pattern for IPF.
I agree.
Because there's not that much honeycombing. It's mostly ground glassy.
Agreed. Yeah.
And there's some subpleural sparing and
yeah.
Yeah.
So, all right. And then my last case was this one here. So this was a patient who came to our hospital actually for something unrelated to their lungs. They were transferred here to our neurology/neurosurgery service for these little ring enhancing things in the brain that were felt to be bacterial pyogenic abscesses. And so they're getting treated for that. But, while they're here, for whatever reason, they get a chest x-ray and then end up getting chest imaging. And this is what their chest CT looks like. So this is our current CT here on the left, and we were able to get an old CT from 5 years ago here on the right. So we've got very extensive perihilar, dense consolidations with areas of calcification and associated fibrosis, architectural distortion, and then obviously a cavity here in that right side. They also have these nice calcified mediastinal lymph nodes. And so it turns out that this is a patient who for a while was being treated as sarcoid, but then after further digging into their history is a construction worker doing stonework for the past 20 years.
I was just to ask about
yeah, exactly. So this was felt to be progressive massive fibrosis from silica exposure, so silicosis. And then I think the thing that was interesting to me was, obviously they have developed this cavity in here, and we know that there is some association between this disease and patients being a little bit more susceptible to TB. So particularly given what was going on in the brain, we, brought that up as a possibility. And they did test the patient, and all of the TB tests were negative. So I think it's just the cavity is just related to their PMF. But it was just a really nice case of progressive massive fibrosis in this patient that the neurosurgery service was like, we don't know how to deal with this.
So what was the assumption then about the brain lesions?
I think they're still I think they don't know what specifically caused it, but they were felt to be bacterial because they improved over time on just standard antibiotic therapy.
Okay.
Yeah. But yeah, the patient, went and got a bronch, and they did lavages and everything up here in that right upper lobe to look for TB, and all of the tests have been negative.
Yeah. I've seen a few cases of progressive massive fibrosis that cavitated from just necrosis and not infection, but you're absolutely right. You always have to query TB or some other infection.
Yeah.
I've seen,
Okay. And cancer.
Aspergillus. Yeah,
Right.
cancer, of course.
Yeah.
Too.
Yeah. But yeah, this is, I guess, unfortunately, because we have been seeing this not that uncommonly now in younger people. This is a relatively young person. This is a young person, I should say. They are younger than I am. This person is only 37 years old, so they got, referred to our pulmonology and possible transplant service.
So the stone was like paving stones was, or was it?
I
It
don't.
wasn't countertop fabrication.
I'm not
was
sure.
it?
It didn't specifically say countertops in the notes, but we've had definitely many people refer to our institution who that is their exposure, is the like sanding of those artificial marble countertops. This just
they
said
seem to develop it at a faster rate in a younger age, probably because it's like 99% silica.
Exactly.
I have seen silicosis in construction workers cutting concrete and things like that,
They
or
did
sometimes
mention
they're
concrete
excavating.
patient, so
Yeah,
but yeah, those are my cases.
those are great.
Excellent.
I'll
Thank
hand
you,
it off.
Maya.
Thank you all.
We do.
Hot dog. Okay. So this person has had a liver transplant. So I take it back. This person has systemic lupus erythematosus, and at this point is in her young 20s. She's had this diagnosis of lupus since her early teens, like 12 or 14, and she's got these holes in her lung down here, which are kind of upsetting. So let's check it out on CT. So she's got this extensive set of cysts or emphysema here. She's a non-smoker, and she went on to get a lung transplant. Now, what do you think? Are these cysts or is this emphysema?
Yes. Some look like cysts. I mean, some of them don't have anything in them and have walls. Other ones, especially in the upper lobe, like right there, that one has a vessel in it.
Yeah.
This one down here has a vessel.
Yeah, but some of them clearly have walls and some of them don't. Well, you can get emphysema if you're a non-smoker. I mean, I've seen it with a rare vasculitis, but that doesn't slip by. That's the hypocomplementemic urticarial vasculitis. She get undiagnosed alpha-1. You said liver transplant?
No, that was
Okay.
that was the wrong list, dude. So
I mean,
liver transplant.
Could it be a weird lamb? That's the other possibility.
So she went on to lung transplant, and it wasn't anything except they called it emphysema. They looked for LIP, which has been associated with lupus in some cases, not very commonly, but has been reported. And it wasn't LAM, and it wasn't histiocytosis. It wasn't anything. So they ended up, she carries the diagnosis of cyst/emphysema as the cause of this. And she was alpha-1 antitrypsin. That was tested, and it wasn't there. Although, there's better testing than the ordinary. I think the Mayo Clinic does extra special testing that picks up a lot more genetic variants of, antitrypsin deficiencies. So she got a lung transplant at the age of 22 or something like that. So this is about 2006, and then At that point, her lungs, lung volume was a little bit low, but her lungs were nice and clear. And then let's fast forward to the current era now in the 20s. And you can see that on her current chest radiograph, she looks as if she's got some holes in her lung again. And on CT, she seems to be getting these emphysematous or cystic spaces again. And once again, they do have some contents. Here's a vessel floating in the center of this. So this is probably better off calling this emphysema, this patchy, very discrete emphysema pattern here, but there are contents in these cysts, so I think emphysema is a better description. So it seems to have come back, whatever it is. Never been a smoker, doesn't use marijuana, and things like that. So this is kind of out of the blue. People don't really know what's going on here, but it has now recurred in her lung transplant. And she doesn't have BOS. She doesn't have, chronic rejection causing this lung disease.
Yeah, because I was
So this is
wondering
bizarre. Yeah.
pre-transplant if maybe she had some undefined mutation in some sort of collagen or something that was causing the lung to
Right.
not be a healthy lung, but that should be fixed by a transplant. So maybe she's got something that's is messing with the metabolism of her, the various catabolism and metabolism of the lung that's causing the tissue to sort of like when you have alpha-1 antitrypsin deficiency. It's
Yeah.
interesting, in that right lower lobe, it's surrounding that vessel. It's almost like it's perivascular.
Yeah.
If you follow that out.
Right. So I did
Well,
find this, I found this article here. You can see it, right?
yep.
SLE associated with multiple lung cysts, and the picture that they included here has a lot of similarities. I think there is some contents to some of these spaces in this person, for instance, down here and down here. So they're not all pure cysts. They call these things cysts, but I think some of them are ambiguous and whether we might be better off calling it emphysematous spaces too. So that's similar here. And there wasn't anything that they picked up on this person. And there are other case reports of actual LIP in association with lupus, although it's not a common association.
Right. Probably more overlap and
Yeah.
not really LIP, but protein deposition.
Okay. And then this person had a liver transplant. So this is the liver transplant person. And we have this old radiograph, and then we have more recent radiographs with diffuse lung disease and ill-defined nodules throughout. And CT confirms lots of lung nodules, many of which are pretty peripheral, some of which have some air bronchograms in them, but not prominent ones, but just tons and tons of nodules, pleural effusion. And then, I don't know whether you can see it very well here, lots of big low attenuation liver lesions too. So lots of stuff going on here in both liver and lung, tons of nodules. So nocardia, too much for nocardia. Does nocardia affect the liver?
I don't see why it couldn't.
So what's the vote?
Cryptococcus, it's a
What do you
lot of
guys-
disease. So usually like things like
Yeah.
aspergillus they're too sick.
Mhm.
Cancer would be on my list, lymphoma.
Mhm.
It's too much stuff for PTLD, I think.
Yeah.
Okay, well, that's what it was. It was PTLD.
Was it
And
a
it was
frank lymphoma or was it more
It was
like
diffuse large B-cell lymphoma.
yeah, now when I've seen that in the lungs, it's been nodular disease. In my case was the same, but it was a single nodule. But I've seen it look like Mets as well, but that's
Okay.
very uncommon.
Yeah.
Okay, well,
Okay. So
EBV
this is a
strikes
pretty
again.
enthusiastic PTLD here. We call this exuberant PTLD. Okay. Okay.
For sure. Wow.
And okay, so this woman here is 76 years old, and she's a lifelong non-smoker. She doesn't use recreational drugs. She doesn't smoke marijuana. And she's got these slightly dirty looking lungs with some small nodules at the periphery and stuff like this. And then if you look carefully, there's a suggestion of some mosaic attenuation. Here's some low attenuation stuff here, and she did get expiratory views. One of these is really good, the other isn't. Okay, yeah, so this one I think shows that there is some air trapping, particularly in the lower lobes. This one may be better. Yeah, this one I think shows it a little bit better. And then we've been getting these minute expiration things. Have you seen this? I don't know whether you guys do these, but this really
I mean,
brings out the
yeah,
low
Yeah, I've been
attenuation
making
stuff.
them myself. I
yeah, I
find them
don't
very
do them
helpful.
regularly,
You know,
but yeah, they can be helpful.
so and she's barely symptomatic. She's obese and she's being followed for lots of other things, but this lung stuff came up recently. And the exposure here, according to her history, is that she used to spend a lot of time cooking tortillas over wood fires. So this is probably smoke inhalation as the cause of her airways disease here and her air trapping. So this is from wood smoke, from cooking tortillas in her case.
Hmm.
Now, in California, and you guys in the Midwest have been exposed to a lot of wood smoke, you guys from Canadian fires and things like that. So wood smoke is not benign. It's natural, but it's not benign. So
Right. Well, it is particulate, but we're of
right.
course lower concentration and it's up in the atmosphere. But no, I mean, you do see that biomass lung causing
Yeah.
various manifestations of COPD. I've seen
Right.
fibrosis. I've seen air trapping. I've seen
Yeah.
big, Seth showed that case of those big masses that looked like sarcoid almost, this huge dense, or like pneumoconiosis, and that was
Mm.
biomass as well.
Yeah. We used to see this in Cantonese populations because there in southern China there was often this cooking on these things called kangs, these ovens in small spaces where they had wood fires in their dwellings and stuff like that. That caused a lot of airways disease. So there was a lot of smoke exposure from that. So in the past I've seen a fair number of Cantonese patients who had things like that. I think that was in my San Francisco days.
I've always said the
Um,
only thing you should inhale is atmospheric air, but I now have to put an asterisk behind that because, of course, when the AQI is over 100 because of Canadian wildfires, well, maybe you
yeah.
shouldn't be breathing that either.
Yeah, there's
Absolutely.
there's air and then there's air, right?
Yep.
Right.
Okay. So
Right.
this
But see,
person
this is an
has,
interesting topic because I get asked around about people, a bunch of people ask me about vaping and lung disease. And of course, we've reported acute lung injuries, and I don't think we really know the long-term effects. But given that there's really no particulates, I suspect we're not going to see the RB, DIP, even maybe emphysema, or at least as bad emphysema, because I suspect a lot of that is from the particulates. Um, because there have been case reports of RB and diesel workers and diesel
Mhm.
engine people around the fumes a lot, because of course diesel exhaust is very particulate heavy. So that may be one of the plus sides of vaping is you avoid the particulates, but then you still have the aerosolized gas, which of course can cause lung disease as well. So who
Yeah,
knows, right? But that's the thing with marijuana too. If you're smoking marijuana in a joint, you get particulates versus if you're vaping marijuana, you're just getting the THC in an aerosol. So it's unclear, but I think it's going to be very interesting to see in the next couple decades or so if the what the long-term effects of vaping are, since vaping's only been around for like 15 years or so.
yeah, but there's so many different things too in different vape products. I mean,
Right.
wasn't one of the toxic products supposed to be the vitamin E acetate,
Right.
stuff like that, oil?
Right.
So,
Which
yeah,
was interesting, yeah, because no one ever actually found like lipoid pneumonia. But again, you don't have these small particles that you see with dust diseases and cigarette smoking. I don't know. It'll be interesting to see.
yeah. And the other thing, it may not just be the oiliness of it, but it may actually be something in the compound or the combustion products of that compound
Right. And I'm
that is
sure
lung
there's
toxic. Yeah,
bunch of cyclical hydrocarbons that are probably carcinogenic.
yeah. Okay, so here's a person with this mediastinal mass, seems to be adjacent to the esophagus. And this is, let's see, what year is this? This is This is 2018. So they followed this up, and we will advance to 2025, and you'll see that this mass has gotten bigger. So it's really important to wait on these things at least 7 years before you before you tackle them, just to see what's going to happen, right? This is a natural history, this thing. It got bigger. No surprises there. So I've not seen this diagnosis before. And here's our esophagus sort of being flattened back here. So what do you think? Slow growing.
Is it a GI stromal tumor of the esophagus?
It turns out to be a typical esophageal schwannoma.
What?
It's actually in the esophageal wall. So it was intramural here. And they pulled it out. They didn't damage, they avoided damaging the mucosa. They reapproximated the muscle layers and stuff like this. It came out very cleanly. And it was a schwannoma. So I've never seen an intramural esophageal schwannoma before. So
it is dense,
live and
which
learn.
Suggests like a high cellularity, but wow.
Yeah. Okay.
Clearly it was benign behaving, whatever it was.
Yeah, we got, 7 years out of it. Okay, that's all I've got. That's my only esophageal wall schwannoma to show today.
That's
Thank you.
amazing. Thank you.
Now we've all seen one.
Yeah.
Okay.
All right. Well, we'll wrap it up there.
Sweet.
Okay.
Thank you all.
Thanks,
Take care.
everyone.
Have a good rest of
Bye-bye.
your week. Bye.
You too.
Bye-bye.